Michelle, thank you so much. That was fascinating and and a real good reminder of why our referral patterns can change so much in this game. So now that we've completed our speaker sessions, we'll move on to the panel discussion. Welcome to the panel, Dr. Larissa Muthing, who is one of our faculty here at CU and one of our resectionists. I'd like to remind everyone, if possible, to use the Q&A function to ask questions or raise discussion points. And I think we'll start off, since in the audience we have a number of luminaries involved in medical education, and specifically with respect to interventional endoscopy. We have Ken, Dr. Edmundovitz, Mahir, Stavros. A question showed up in the chat that I think is really appropriate. Given the volumes needed for ESD and POEM and training, and the disparate clinical expertise involved in those procedures versus hepatobiliary, is there any thought to separating training between those two areas of interventional endoscopy? And I'll start with you, Stavros.
Well, I agree 100% with the comment. I mean, that's why our ESD training curve was a bit unique in looking at the entire all-organ ESD experience. You have these studies that come out looking at stomach and colon, where the operator, before they did colon, may have done like 100 gastric ESDs that they don't count, or zero. So I don't think it makes any sense. And, esophageal ESD is extremely similar to POEM, for example, and so is tunneling in other places. So I think in a perfect world, a POEM learning curve should include the amount of ESD experience. And that's why when I listed my learning curve studies, I put the prior operator experience, whether it was ESD or POEM, or nothing. So it makes a huge difference. So I agree. Now it's difficult. It varies because in some programs I know they have separated DSD from POEM and GPOEM and GPOEM. I'm not sure that makes sense to me because there are so few POEM procedures and not so many ESD ones. But I agree. You should look at it as a submucosal endoscopy experience in total.
Dr. Edmundovitz, any comments? I see your hand raised there.
Stavros, excellent talk, and thank you for putting all that together. I guess the question is, we're thinking about this in terms of endoscopic training, but if you look at surgical training, you think of the experience that surgeons get as the chief resident and then go out into practice. They certainly don't get the numbers of cases that we would expect in an endoscopic practice, particularly a resection practice. Do you think we should shift to teaching techniques, how to do submucosal dissection, how to control bleeding, how to close lesions, and really not focus so much on the number of procedures that an individual needs to do to determine whether they can have competency?
Well, there's a whole debate of how important numbers are. I'm on the number side, because that's something that people understand immediately and that can translate to their own experience. I mean, I agree there's a talent side. You can have a fellow that can master things in 5 cases and another fellow that could master them in 25 cases. So in the end is what are your level of skills at that time. But the problem is when these people graduate, the first fellow will be at a higher level than the second fellow. The thing is, the second fellow will have to do more work on his own then to reach an appropriate proficiency. So I think you have to have the proficiency metrics independent of numbers like percent R0, percent on block, adverse events for POEM. I think that's the main benchmark, because judging how good the fellow is by looking at how they do a submucosal tunnel, I think we should have something more objective. So I think you should judge them on metrics in terms of proficiency. And then how to deal with the difference in talent, I'm not entirely sure, but I like the numbers. If you know that an expert operator requires 100 POEMs, you can be prepared for a good, substantial learning curve. I think that helps. I mean, if you feel you're a little less skilled on that, you might need more. So yeah.
Ken, any comments there?
Yeah, I agree. We have 3 advanced fellows each year, and to expect a fellow coming out of a general GI fellowship doing 1 year advanced fellowship and learn everything is not possible. So we look at it as the first year is first level of interventional endoscopy, EOS, ERCP, EMR, ablation, but then you have a whole continuing to develop subspecialties, whether it's endobariatrics, whether it's third space, and now endohepatology. uh, you can't master all of this. So then fellows who want to continue will stay a second year, or they'll come in already having the EUS ERCP experience and want to focus on third space or GERD. So that's a natural progression of the training as the subspecialties continue to diversify.
Hey, Paul, can I make a quick comment there along the same lines of what, Ken, Stavros, and Steve just said? I think, more than the numbers game, I do know that numbers are important, but what I think is it is important where the person who's training in third space endoscopy was before they started their third space endoscopy training. And, there's a difference when there's someone who's done 5 or 10 years of endoscopy or interventional endoscopy. And if that person wants to learn a newer skill, it's very different from a fellow that, Ken, you gave an example, someone who's done a 4th year and now is doing a 5th year or more advanced training. And as you know, there's a big difference in the skill set of someone who's a seasoned interventional endoscopist or has been doing it for a few years. So I think those folks might be able to grasp these techniques much faster. So I think what is important is to assess them. And I think right now, we have a tool that we use, and I think Dennis Yang, Peter Dragonoff, and some other colleagues are putting together a tool for assessing EMR and POEM and ESD. So I think that's going to be the way we can actually establish this down the road.
And Dr. Wild, you mentioned during your talk about GPOMs how prior Botox injections may indicate that the patient will respond, but does that injection increase the technical difficulty of the GPOM?
So in theory, yes, but I think that for most of us who do third space endoscopy, the submucosal fibrosis is not that bad that we cannot do it. Sometimes it can get quite fibrosed, but it still allows us to do it. So the answer is it may make it a little more difficult, but I don't think it's an obstacle. And I would not say no for a GPOM if someone has had Botox before. In fact, the first 2 GPOM patients that I did, it was the same referring gastroenterologist who had injected Botox every 3 months for almost 1 or 2 years for these patients, and they had done well with the injections. And I was a little skeptical doing the first 2 GPOMs that way, but they turned out fine. And since then, we don't use that as a contraindication.
On a similar vein, Mahir, to answer one of the questions, can you comment on the double myotomy in GPOM and whether that is useful?
Right. So when I first put my talk together, I did have a slide on the double myotomy technique, and I took it out in the interest of time. So for the others in the audience, what this means is this is published by the Emory group, where instead of doing a single cut onto the pylorus, which typically we do at the 5-6 o'clock position, when you're looking at the pyloric ring, the cuts are done at maybe 4 and 5 o'clock, and then another one at 7 and 8 o'clock. 2 cuts, and the rationale being that you completely separate the pyloric muscle fibers and prevent them from coming together and causing restenosis. And that one study did show some improved outcomes. I have not realistically understood the rationale behind cutting a sphincter in 2 different locations at the same time. I don't know if the others in the group have a different experience or what their thoughts are about this.
Yeah, I'll comment. Yeah, based on the Emory study, I've been doing a double when I feel like sometimes just a single is wide open, like parting the Red Sea, and I don't do a second. But doing a second is okay. One thing I also do is at least one of the two myotomies, I'll extend it a little bit longer along the prepyloric antrum. And there's some theory that that may contribute to gastroparesis, not just the pyloric, but the prepyloric antrum. So I do that. And the other comment, back to Larissa's question about Botox, whenever we do Botox pre-G-POEM, either I or whoever the general GI person who may be considering Botox, I say, please inject 9, 12, and 3 and leave 6 o'clock alone. But whether that's real or not, I don't know. But we never have an issue doing a G-POEM if we don't inject at 6 o'clock. But I don't know,
Go ahead.
I think, Paul, you've asked me many times, is there some part of the pylorus you want me to leave for you so you can do a G-POEM or so? And the answer is I initially used to do what you just mentioned, stay away from the posterior side, but then I find that it makes no difference. And the other thing is that I'm sure that Botox goes everywhere once you inject it in 2 or 3 quadrants. So I don't really have a preference.
Agree. The submucosal Botox goes everywhere. Steve, go ahead.
Mihir and I have had this discussion at length, but I'm really concerned that the G-POEM space is following the pathway of the sphincter of Oddi dysfunction space. And we're really going down a pathway of intervention without well-done randomized controlled trials to help us select the population that benefit. There's no doubt that some patients benefit from this procedure, but clearly it's analogous to the type 2 and type 1 SOD patients that benefit versus the type 3s, and how do we sort that out? Any ideas on how we should go forward with a well-designed study, or is this something we're just going to let the community progress on?
So I'll start and then we can have the others chime in. So I think, Steve, you're right. I think the important thing is I was very skeptical when I started doing these, and I thought that we consent all our patients in a prospective study registry, and we tell them exactly where the procedure stands in its infancy versus well-developed stage. So I started doing it, was skeptical, but some patients do improve. And now with the first reports of a sham study, I know that this is just in abstract form. I think there is some prospective data and sham controlled study data coming out. So I think that's the way to do it. But the first and foremost, I think, is establishing definitions as to what we start with and where we are going. And I think that's the way. Without that, just improvement or reduction in gastric retention, I think is quite vague. And I think establishing that would be the first step. Probably Paul can comment on from a motility side as to what those outcomes need to be.
Yeah, I think it's a struggle. As we all recognize, the methods of diagnosis for gastroparesis are probably insufficient also. And so you have insufficient, you have a heterogeneous patient population, you have probably insufficient diagnostics, and then uncertain outcomes. And I'd be curious from Ken and Mihir and Steve and Stavros' perspective. Steve, you brought up the challenge with the similar sphincter of Oddi specter. How do we feel about the risks compared with sphincter of Oddi treatment? Because from what you guys have presented, the risks, at least given the challenge of gastroparesis patients, seem pretty tolerable from a clinician's perspective.
Well, I mean, I'll comment on that. I think the risks in these expert hands are probably less, but we've already seen this practice extend into the community, and the risks are not insignificant.
We did have a couple of questions about Z-poems, if any of the panelists could answer these. One question was about whether you start with a horizontal versus a vertical incision when starting the Z-poem. Does Mahir or Stavros or Ken want to comment on how they start theirs?
Well, I I start with a circular incision. So I try to make as small a hole as possible. Most of the Zenkers you get are like 2 centimeters, which effectively means I don't use the tunnel in the hypopharynx approach. I use the tunnel starting at the septum. So basically you make a hole right at the apex of the septum and then cut the muscle immediately a millimeter later. So the tunnel forms as you cut the muscle. So what I do is I make a 4 or 5 millimeter hole that allows the tip of the Fuji ST hood cap to get in there. And I never even, in some of them, I don't even get the scope in the quote unquote tunnel. I just get 2/3 of the cap, and by little pressure, you can cut 15 millimeters of muscle, and you end up with a hole that is 4 or 5 millimeters that you can close with 2 or 3 clips. I mean, I suture everything, but that's one place, maybe the only place. I mean, I suture Z-poem, I suture poem for years now. I tried suturing on a Z-poem. It's just not reliable. And the closure, I think, is the most difficult part. Sometimes it takes me longer to close than to the septotomy, and the most concerning part. And, you know, I saw Michelle's talk, but I'm telling you, I've been doing 15 years of septotomies. I got 2 leaks on the Z-poem era of the last 6 years, but no leaks on the direct septotomy previously. So, you know, I think we need to consider the closure of that tunnel and where the tunnel goes posteriorly when we do it by tunneling. I think there's some concerning stuff in the back there near the cervical spine. So anyway, so that's what I'm saying. So I do a little 4 or 5 millimeter hole and then expand it by little cuts enough to get the ST hood in. So I don't do transverse or linear or whatever.
Yeah, so I'll comment. So a lot of my techniques I learned from Stavros, my mentor in this area. Thank you, Stavros. So I also do what's called now the modified Z-poem, where you're actually making the incision right at the bar. I've done initially the tunneling technique, which is okay, but that actually takes longer than the whole procedure, doing the tunneling. So I start at the septum. I do a mini horizontal, but my closure is vertical. Mini horizontal is essentially the small circle that Stavros mentioned, but in a large diverticulum, doing a horizontal, then when you close in the opposite direction, actually brings some of the mucosal redundant tissue, brings it in, and it reduces the pouch size in the larger diverticulum. So doing a horizontal incision and then a vertical closure gives you a little bit of that effect. But cutting the muscle, even as you start, is really a great trick. Because then you don't need to make as large of an opening to expose the muscle and then complete your submucosal dissection.
So I'll just say that Michelle is logging in right now. I think there was some issues with his connection. So he's going to log in and we'll get his input on the Z-poem incision. And until then, I'll just give you what I do. And I think, you know, there has been a change like Ken mentioned. So even I would be starting that incision a little proximal to the septum. And there are a few drawbacks to that technique. One is you can get lost in that space sometimes and sometimes you may not be able to find the septum as readily. The second thing is closing that incision when it's proximal, even further up, gets very close to the upper sphincter. So that can be a very tight space that the closure can be challenging. What we have now done is just what the others have said, which is going straight onto the septum itself to start. And in essentially, it's not a tunnel anymore because you're cutting right on top of the septum and then maybe tunneling right and left of the septum and exposing the septum and doing the myotomy. And that has 2 advantages. It saves you a lot of time. Our procedure time came down from 45-50 minutes to about 30 minutes or so, or 25, 30 minutes when you start right on the septum. And then you can close it. You have more space there to close it with clips. And I think there was a question as to what clips we use. And I'll say that this is the one time when I do prefer the clips with a shorter tail, because then it doesn't stick into the proximal esophagus or the UES. And it's a little easier to navigate that space and probably more comfortable for the patient as well.
I agree, Mihir. The only situation where I will tunnel is when there's no diverticulum, but there's a tight CP bar. Then I want to start a couple centimeters proximal.
Agree.
And that was actually, thanks, Ken. That was actually one of the questions brought up by Dr. Deal, whether there was a modification for Z-poem that, including treating a cricopharyngeal bar.
Maybe while we're waiting for Michelle to log in, going back to GPOM, Dr. Reveley had a question of whether there's a role for endoflip in understanding the pylorus destruction in stratifying those who might respond to GPOM. If Mihir or Paul, you want to comment on that?
So I'll let Paul go since he's the motility guy.
Yeah, I think Mihir addressed it briefly, and I'll get to it over lunch. But essentially, it's likely an imperfect diagnostic tool, but there's some small evidence. Mihir brought up the challenges to that evidence that that impaired distensibility of the pylorus may be able to predict people who would benefit from GPOM, and that there might be, and that with GPOM, there's an increase in distensibility of the pylorus that maybe can predict some responses. But then we'll also just echo Dr. Edmundovitz's concerns that all of these are very small, retrospective, predominantly data, in a heterogeneous patient population. But given the challenges in diagnostics in gastroparesis, I think it's a not unreasonable thing to continue to examine. Mihir, how easily have you found it to be to endoflip the pylorus?
So from a technical standpoint, it's doable. I think the bigger question is, what are we starting with? Because I saw a study from Nagi Reddy's group. I think they took a few normal volunteers and did an EGD and did an endoflip to find out what the normal cross-sectional area and DI is. And if I remember right, the DI was somewhere in the 6 to 8 range in those normal healthy volunteers. And the data that I showed you recently in the talk looked at the DI going up, but it was still in the same kind of range. It didn't seem to be that those patients had a lower DI to begin with, and then it went up. So I'm not entirely sure what the distensibility of the pylorus does in the grand picture for gastroparesis, and whether that's something that needs to be assessed. And I don't have an answer for that.
Yeah, and I believe there was actually it's also a DI of less than 10 was examined as a threshold. And how about a trick to getting the endoflip catheter across the pylorus to answer Dr. Deal's question?
So I don't have a trick. I think it can get cumbersome, but it's doable. So I don't know if the others have a trick up their sleeve.
You can use the clotbuster scope if you have it. I don't think Olympus makes it anymore. It's a 6 millimeter channel scope. That makes it really easy, but you need that scope.
That's a better answer than mine, which was a strong arm.
One trick for difficult endoflip placement is you can actually backload the very tip of the endoflip back into your biopsy channel at the tip of the scope. Your view is a little bit obstructed, but you can pass the scope down, and so the endoflip will follow you, whether it's through the G junction or through the pylorus, and that's one technique. But I did a bunch of endoflip pre-poem, and I think it takes longer to do the endoflip than the G-poem.
Thanks. I didn't know about that backloading tip. That's a good one.
The Indiana group was debating. I remember when I gave grand rounds, they had a technique where the balloon is in D2, or where the balloon is in the bulb, because that's the other thing, they're getting it in D2. So which one do you prefer? I mean, I leave the balloon in the bulb. I think that it kinks when you try to put it in D2, and you also have to make sure it's not kinked in the stomach, because then your data are a little. So you leave it in the bulb, or you try to get it in D2 and then withdraw and center it on the pylorus. Anyone?
I would say I just get it across. That's the important thing. And I'm very hesitant about these balloon pressure measurements, as Steve was referring to, having done sphincter of OD manometry in the past. You can make many things measure differently in different ways, doing it at the same time. So I'm a little cautious about it, even though I do use end of lip for my achalasia and for my EPOM patients.
I think Steve should leave the episode equivalent and be the Peter Cotton for G-Poem.
No, thank you.
Unfortunately, we are out of time. I want to thank all our speakers for providing us with their expertise, as well as all of the audience for excellent questions. APIE would not be possible without the generous support of our sponsors. So I do want to thank Apollo Endosurgery, Boston Scientific, Cook, Creo Medical, Endogastric Solutions, Irby, Fujifilm, Healthcare Americas, Interscope, Medtronic, Microtech, Ovesco, Pentax, Pfizer, and Steris. Please visit the sponsor hall during the break. You can enter the hall during the link in your email, or Christy will provide it in the chat box now. And then don't forget that all the exhibitors will be live from 2:40 to 3:20 this afternoon. And if you do visit 5 exhibitors, you will be entered to win an $100 gift card. Christy will also post the links to claim CME and MOC, as well as nursing contact hours in the chat box later today and on the course website. And then please don't forget to come back at 11:10, where we will have an exciting session on bariatric endoscopy. Thank you, everyone.
Hey, Larissa, can I just interrupt for a second? Dr. Kahela just joined us. I think there were some issues logging in. Hey, Michelle, welcome. Sorry, we were running a little ahead and there were some technical issues. There were some questions about the Z-Poem incision and closure technique. And so, the panel was giving their input, but since you're with us now, could you comment on on the type of incision and how you close it and what clips you use?
Yeah, this is actually a great question. Sorry for the delay. I literally just got the link. So basically what I like to do is 1.5 centimeters to 2 centimeters before the septum. I typically open horizontally, like perpendicular to the septum. That allow you to drive very easily into the tunnel and ride the septum from the inside. And then to close, actually, I close it vertically, and I like to use the small clip of 11 millimeter from ConMed. I like those clips. They're very nice, they're very small, and they're very efficient, because you are in a very tight space. You really don't have enough space to put the large 13 millimeter clip. And typically within a few days, as you know, they pass and the patient is able to eat without an issue. You muted me here.
I was just saying thank you. I think, we've heard from different people, different styles of incising and closing. And, Peter Dragonov and I recently wrote a how I do it kind of thing on Z-Poem. And the punchline there was, it doesn't matter how, you just need to cut the septum. So I think there are all these different ways. As long as we can cut the septum, patients do well. And so that's the name of the game.
Yeah. I mean, I think we published this data. We compare the Z-Poem to the cetotomy technique. I think that the beauty about the Z-Poem, you are protected because it's a third space technique. Whatever happened in the tunnel, as long as you close the tunnel, you're safe. I think that's one of the advantages compared to the conventional septotomy.
All right. Well, Michelle, thank you so much. And I think we're running out of time now. So we'll go ahead with our next session. Is that on the agenda next?